if you were to walk into pretty much any emergency room or cardiology ward right now
Mm.
and just look at the unspoken rules of medical dogma.
Oh, the rules that are essentially set in stone.
Right, exactly. Somewhere near the very top, like in bold red letters, it would definitely say, keep heart failure patients away from salt.
Absolutely. It's one of those universal, unquestioned truths in medicine.
Yeah, because think about it. You have a patient whose heart is failing. The pump is weak, so their body is actively drowning in excess fluid.
Right. We're talking about legs that are so swollen that, pressing on the skin leaves a deep indent.
Yeah, pitting edema.
Exactly.
Mm.
Or lungs that are so congested they have to sleep cropped up on like 3 pillows just to catch a breath.
Which has to be just terrifying.
It is. It's a terrifying state for a patient to be in. And the entire clinical focus in that moment is just, getting rid of the water.
Right. So common sense dictates that the very last thing you would ever do. I mean, the thing that sounds like absolute malpractice on paper is hook that drowning patient up to an IV and pump highly concentrated hypertonic salt water directly into their veins.
Yeah, giving salt to a person who is essentially dying from too much fluid.
It sounds nuts.
On the surface, it sounds like throwing gasoline on a fire, honestly.
Seriously.
Because, we are taught from day one of medical training that sodium acts as a sponge for water in the human body. So giving sodium to a volume-overloaded patient, well, it contradicts the most fundamental principles of volume management.
Which is exactly what makes our mission for this deep dive so incredibly compelling.
It really is.
Because we have this stack of clinical evidence sitting right in front of us, and it's completely flipping the script on how to treat acute decompensated heart failure, or ADHF.
Yeah, the data is just, it's striking.
We're diving into this landmark 2021 meta-analysis published in Critical Care Medicine by Liu and colleagues, as well as a massive 2023 review from Clinical Cardiology.
Both really robust sources.
Very robust. And our goal today is to uncover how taking that exact patient, the one struggling to breathe, and giving them a combination of hypertonic saline and a standard diuretic drug called furosemide is, well, it's not just working. It's saving lives.
It's a fantastic mission for us to tackle. And honestly, it's one of the most fascinating examples of challenging, entrenched medical assumptions that, we've seen in recent years.
Oh, without a doubt.
For decades, that traditional dogma has been strictly enforced. It's almost a reflex, right? Heart failure means strict sodium restriction.
No salt, ever.
Right. Yet when we actually look at these specific studies, we see that giving these patients salt in a highly specific, controlled manner makes them live longer, keeps them out of the hospital, and miraculously preserves their kidney function.
It's a total paradox. And I think to really grasp why this counterintuitive, heavily salted treatment works, we first need to understand the biological brick wall that doctors hit when they use the standard treatment.
The drowning problem.
Exactly, the drowning problem. So a patient gets admitted for ADHF. They're critically overloaded with fluid. The standard of care is to give them what are called loop diuretics, usually intravenous furosemide.
Right.
And the whole point of that drug is to force the kidneys to produce urine, right?
Yeah.
To essentially wring out the body and just get rid of that fluid.
That is the standard playbook. And, initially in the early stages of heart failure, that often works beautifully.
The patient urinates heavily, the swelling goes down, and they can breathe again.
Right. But the massive hurdle we run into with severe advanced heart failure is this phenomenon known as diuretic resistance.
Which sounds incredibly frustrating for the doctor.
Oh, the clinical picture is incredibly frustrating. You have a patient who is still dangerously congested, so the doctors do the only thing they know how to do, which is increase the dose of furosemide.
To just pump more in.
Yeah, they might escalate it all the way up to like 1,000 milligrams twice a day, which is a massive aggressive dose. But despite all that medication, the patient's urine output completely stagnates.
So they just stop peeing entirely, even though they're pumped full of drugs literally designed to make them pee.
Yes, and the situation deteriorates rapidly from there. You look at their blood work, and this specific marker called serum creatinine starts creeping up.
And for anyone who's ever looked at a metabolic panel, you know that when creatinine goes up, it means the kidneys are struggling to filter waste.
Exactly.
So the kidneys are effectively starting to fail, all while the patient is still suffocating under the weight of their own fluid.
Right.
Now, I have to push back on the medical logic here for a second, because if you're looking at this from a purely mechanical standpoint, if the plumbing is backed up and the fluid isn't draining, Why is the standard response to just keep turning up the water pressure by pumping in more and more diuretics?
It seems counterproductive, doesn't it?
Yeah, like doesn't the kidney eventually just tap out from being whipped so hard?
Well, if we connect this to the bigger picture, we have to look at the body's deeply ingrained evolutionary survival mechanisms.
Okay.
To understand why the kidney taps out, we have to remember that human biology evolved on the savanna, not in a modern cardiac intensive care unit.
Right.
The human body does not have a biological sensor that says, "Warning, my heart valve is failing."
It doesn't understand chronic disease at all.
Exactly. When you give these massive doses of loop diuretics and rapidly remove fluid from the bloodstream, the effective circulating blood volume drops.
The actual volume of liquid moving through the blood vessels themselves decreases.
Yes.
Even though the tissues like the legs, the lungs are still swollen with water, so the fluid is essentially just trapped in the wrong place.
That is the core issue right there. The fluid is hiding in the tissues, but the blood vessels are getting depleted. And when the kidneys sense this sudden drop in blood volume, the body relies on its ancient programming. It panics.
It thinks it's dying.
Right. It assumes you've just been attacked by a predator and you're bleeding out. Or maybe that you're wandering in a desert and are severely dehydrated.
So the body hits the emergency alarm, completely unaware that the patient is actually sitting in a hospital bed with like an extra 20 pounds of water in their legs.
It hits the alarm incredibly hard. It activates these powerful neurohormonal systems, specifically the renin-angiotensin system and inflammatory markers like tumor necrosis factor alpha or TNF-alpha.
And what do those alarms actually do?
They aggressively instruct the kidneys to stop producing urine immediately and to hoard every single molecule of sodium they can find.
Because salt holds water.
Exactly. The body knows that salt holds onto water, and it thinks holding onto water is the only thing that will save it from bleeding to death.
I love that visual. It's like the kidney turns into a doomsday prepper, right?
That's a great way to put it.
The doctor is sending in a drug saying, hey, flush out the sodium in water. We have way too much. But the kidney has locked itself in a bunker, hoarding cans of salt, screaming, the world is ending, hold on to everything at all costs.
That is a perfect way to describe it. The kidney becomes completely resistant to the diuretic because of this physiological panic attack.
Wow.
And pushing higher and higher doses of furosemide, at that point, it doesn't just fail. It actually makes the kidney function worse because you are exacerbating that perceived state of dehydration in the blood vessel.
Okay, wait, let's unpack this. Because this brings us perfectly to the biochemical solution, which is where the hypertonic saline comes in.
Right.
If pumping more diuretics fails because the kidney is trapped in a state of sheer doomsday panic, we have to figure out how to biochemically break into that bunker and turn off the alarm.
And that is precisely the elegant mechanism of hypertonic saline. It tackles the panic on multiple fronts.
I want to give the listener an analogy to help visualize this. Think of hypertonic saline like a molecular sponge being dropped directly into the bloodstream.
Okay.
Because it is so unbelievably salty and concentrated, it acts like a magnet. It pulls all that trapped, stagnant water out of the waterlogged tissues, out of the lungs, out of the swollen ankles, and pulls it back into the blood vessels where it actually belongs.
A great visualization.
Or, you can think of it like a conveyor belt that suddenly delivers the exact raw materials the diuretic drug needs to actually do its job.
Those analogies map brilliantly onto what is happening at the cellular level. If we look closely at the source text, the mechanism of why adding this heavy salt solution works rests on three main pillars.
Okay, let's break those down. What is pillar number one?
The first pillar is your sponge analogy. We call it the osmotic pull.
Okay.
Hypertonic saline increases plasma osmolality and oncotic pressure. To put simply, osmolality refers to how concentrated the blood is, and oncotic pressure is the pulling force exerted by proteins and salts.
So by shooting highly concentrated salt into the vein, you make the blood thicker and saltier.
Yes. Nature hates an imbalance, so water rushes from the swollen tissues into the blood vessels to dilute that salt.
It's just physically pulling the water out of the hiding spots.
Exactly. And when that happens, renal perfusion, which is the actual physical blood flow reaching the kidneys, significantly improves. The kidneys suddenly feel this nice, full rush of blood volume.
So the kidney feels that rush and says, oh, okay, the blood vessels are full. We aren't bleeding out on the savanna after all. We can relax.
The doomsday prepper steps out of the bunker.
Right.
The kidney stops panicking, so that's pillar one. Pillar two is hormonal suppression. Remember those panic alarms we just talked about? the renin and the inflammatory TNF-alpha.
Yeah, the siren's telling the kidney to hoard all the sodium.
Well, the sources show us a fascinating biological quirk here. Introducing these high-salt conditions directly into the kidney actually stimulates renal TNF-alpha in very specific tubule cells.
Wait, I thought TNF-alpha was part of the panic.
It usually is, but paradoxically, in that specific location, it inhibits the expression of angiotensin. It biochemically short-circuits the body's desperate attempt to reabsorb sodium.
That is wild. So the salt itself is the off switch for the salt hoarding panic?
Yes.
It's like feeding the doomsday prepper so many canned goods that they finally agree to open the bunker door.
It is an incredible negative feedback loop. And that brings us to the third pillar, which is your conveyor belt analogy, substrate delivery.
Right, the raw materials.
We have to look at how the drug furosemide actually works. It functions by binding to and blocking a specific transporter in the kidney called the NAK2Cl cotransporter, or NKCC2.
So NKCC2 is basically a microscopic doorway, or like a turnstile that usually pulls sodium back into the body.
Right.
And furosemide jams that turnstile so the sodium and the water attached to it gets flushed out as urine instead of being reabsorbed.
That's the mechanism. But here is the catch. If the body is hoarding sodium so aggressively earlier in the kidney's filtration process because of that panic, there is almost no sodium actually reaching that specific turnstile.
Oh, I see.
If there is no sodium traveling down the conveyor belt to reach the transporter, the furosemide has nothing to act on. The drug is just sitting there guarding an empty doorway.
Ah, so the diuretic is completely useless because there's literally no salt to block.
Exactly. By giving hypertonic saline, you deliver a massive sudden load of sodium straight down the pipe to that loop of henolin in the kidney.
You're essentially giving the drug something to grip onto.
You give the factory the raw material it needs so the machinery can actually run.
I mean, the theory is just beautiful. We aren't just hitting the body with a bigger hammer. We're essentially hacking the body's own fluid dynamics to trick it into healing itself.
It is a brilliant physiological workaround. But of course, as any medical professional will tell you, an elegant biochemical theory under a microscope is one thing.
Right. Translating that biological hack into actually surviving severe heart failure in a hospital bed is a totally different ballgame.
Absolutely.
Like, does this actually work for human beings? Or is it just a neat trick in a petri dish?
Well, the clinical data is where this story evolves from an interesting physiological quirk into a potential medical paradigm shift.
But here's where it gets really interesting, right?
Yeah.
I want to lay out the numbers for you because they are staggering.
They really are.
We're looking at the 2021 Lu meta-analysis, which pooled data from 11 randomized controlled trials involving almost 3,000 patients. And this was fully backed up by the 2023 Acute meta-analysis.
Yes.
When researchers compared patients who received standard furosemide to patients who received the hypertonic saline plus furosemide combination, the all-cause mortality was slashed.
The relative risk was 0.55.
Which means the risk of dying was cut almost in half. The text notes this equates to 123 fewer deaths per 1,000 patients treated.
It's huge.
In cardiology, finding a single intervention that prevents 123 deaths per 1,000 is massive. It's a kind of number that normally makes headlines.
It is a profound mortality benefit, and the positive outcomes extended far beyond just survival rates.
Yeah, let's talk about the quality of life metrics because heart failure readmissions are a massive burden.
Oh, totally.
These patients are constantly bouncing back into the hospital because the fluid just builds up again. But with this treatment, hospital readmissions were also cut in half with a relative risk of 0.50.
Think about what a 50% drop in readmissions means for an overwhelmed hospital system.
It's incredible. Plus, patients who got the salt and diuretic combo left the hospital over 3 days earlier.
They cleared the fluids significantly faster.
They peed out an extra 584 milliliters daily. That is more than half a liter of extra fluid removed every single day.
Right.
And they lost an additional 1.76 kilograms of weight compared to the people just getting the standard diuretic alone. I mean, they're literally draining the swamp.
Yeah, and what's fascinating here is one specific data point that, frankly, shocked a lot of people in the medical community.
What's that?
And that is what happened to the renal function.
Oh, because conventional wisdom says pushing the kidneys this hard should destroy them.
Exactly.
Forcing a failing kidney to process a massive hypertonic salt load while simultaneously hitting it with high-dose diuretics. It sounds like a recipe for frying the machinery entirely.
That was the overriding fear. But the combination therapy actually decreased serum creatinine. On average, it dropped by 0.41 to 0.46 milligrams per deciliter.
And as we established earlier, dropping creatinine means kidney function is actively improving.
Significantly improving. By restoring that effective circulating blood volume and easing the panic, the therapy improved the glomerular filtration rate, the actual filtering capacity of the kidney.
So it's protecting them.
Yes, the hypertonic saline therapy proved to be renoprotective. It protected the kidneys from failing while allowing the diuretics to safely strip away the excess fluid.
It's incredible. It slashes mortality, halves hospital readmissions, clears the fluid out faster, and protects the kidneys.
It hits every mark.
Which immediately makes you wonder, if this protocol is so undeniably effective across the board, why isn't it the immediate, unquestioned standard of care in every single emergency room on Earth right now?
Why isn't every doctor doing this?
Right.
And that is the necessary reality check we have to perform. We must address the limitations of the research and the legitimate hesitations in clinical practice.
Because, hold on, I have to stop you. If I'm a doctor in that ER, alarm bells are ringing in my head. You're telling me to give an IV bag of highly concentrated salt to someone whose lungs are already filling with fluid.
I know.
Doesn't that trigger flash pulmonary edema?
Yeah.
I'd be absolutely terrified of the sudden rush of fluid into the blood vessels, overwhelming an already weak heart, and just instantly backing up into the lungs.
Your reaction is exactly why clinicians hesitate. It feels deeply counterintuitive, but let's look at the safety profile based on the clinical data we actually have. A retrospective analysis specifically looked at 58 severely ill patients who received this therapy. These were incredibly sick individuals, prime candidates for complications.
Right.
Yet the data showed absolutely no respiratory decompensation.
So the flash pulmonary edema fear just didn't materialize in the real world.
It didn't. There was no worsening of pulmonary edema, no increased need for oxygen support, and no changes on their chest x-rays indicating their lungs were taking on more fluid.
Wow.
The theory is that the diuretic kicks in fast enough, thanks to the newly delivered sodium, to handle the fluid shift before it can back up into the lungs.
Okay, but there's another major safety fear with giving IV salt that we have to talk about, right? Osmotic demyelination.
Yes, a very serious concern.
Yeah.
Osmotic demyelination is a type of severe, often permanent brain damage that occurs if you correct a patient's low sodium levels too quickly.
The brain cells essentially shrink and get damaged if the salt concentration in the blood spikes too fast. And the danger zone for that brain damage is shifting the blood sodium levels by 6 to 8 millimoles per liter in a 24-hour period. If you're pumping highly concentrated salt into a vein, aren't you risking blowing right past that limit?
You would think so, but the clinical data showed the median sodium increase with this specific protocol was only 1.5 millimoles per liter at the 24-hour mark.
Oh, wow.
It was well below the danger zone. Across these studies, they didn't observe a single case of osmotic demyelination.
All right, so the immediate safety fears, the drowning lungs and the brain damage, seem to be largely addressed by the data.
Yes.
But what about the research itself? We have to look at this impartially. If the stats are this good, there has to be a catch in how the studies were conducted.
Right, which raises an important question and is where we have to impartially examine the grade criteria evaluation of this evidence. The grade system is the international standard scientists use to evaluate the certainty and quality of clinical evidence. And despite these jaw-dropping mortality and readmission numbers, the certainty of the evidence for this therapy is only rated as low to moderate.
Wait, really? Why is that? If the results are so overwhelmingly clear, why the low confidence rating?
Because the vast majority of the positive research comes from a very limited, highly concentrated number of research groups.
Oh, I see.
When you dig into the citations of these meta-analyses, you see the exact same names appearing over and over, specifically studies by Paterna, Licata, and Paranello.
So it's a small cluster of experts driving the bulk of the data.
Exactly. They have done incredible pioneering work. But in evidence-based medicine, whenever a huge chunk of your data comes from a single cluster of researchers at specific centers, it raises methodological concerns.
Right. It raises the risk that their specific patient population might not reflect the rest of the world, or maybe there could be unintentional data duplication.
Precisely. Without broad, multi-center global replication in completely different healthcare systems by unaffiliated researchers, the wider medical community will always maintain a level of skepticism.
And that makes total sense.
You need diverse, independent verification before you rewrite global cardiology guidelines.
That is entirely fair, and it's a crucial piece of context for anyone reading these glowing studies. So, synthesizing all of this, who actually gets this therapy right now? Because we certainly aren't saying that every person with a weak heart should go start chugging salt water at home.
Definitely not. The clinical consensus on the ideal patient for this protocol is very narrow and specific. It is a targeted therapy, not a general lifestyle recommendation.
It's specifically targeted at patients with acute decompensated heart failure who have severe fluid overload
Yeah.
and who have already demonstrated that stubborn diuretic resistance.
Right. They have to be failing the standard therapy first. Furthermore, it is particularly indicated for patients who have impaired renal function alongside their heart failure, a condition we call cardiorenal syndrome. And potentially, it's utilized for patients who also present with hyponatremia, which is abnormally low blood sodium.
For that specific critically ill patient, what does the actual treatment look like in practice?
The most typical protocol studied is administering 150 milliliters of 1.4 to 4.6% hypertonic saline.
Okay.
That is given twice daily, and crucially, it is given alongside a high dose of intravenous furosemide.
So it's a very targeted, precise intervention.
It is a surgical strike with sodium in an intensive care setting, not a blanket recommendation to remove dietary salt restrictions.
So, what does this all mean for you? Let's zoom out and distill this entire deep dive. The ultimate takeaway here is that treating the human body isn't as simple as a rudimentary math equation.
No, not at all.
It is not just fluid is bad, therefore forcefully remove fluid. The body is a complex, deeply interwoven network of ancient evolutionary alarms and biochemical feedback loops.
And by taking the time to truly understand those interconnected loops, we learn that sometimes the only way to solve a biological problem is to think paradoxically. Sometimes, giving the body a little bit of what it seems to have too much of in this case, salt is the only way to calm its internal doomsday alarms down so the modern medicine can actually work.
It's incredible. And the reason this matters to you, whether you're a medical professional trying to save lives or just someone who is insanely curious about how the human machine operates, is because this is a brilliant masterclass in critical thinking.
It really is.
It proves that rigid, unquestioning adherence to dogma, like the idea of universal sodium restriction for every single heart failure scenario, can sometimes create a massive blind spot.
A huge blind spot.
It can blind us to highly effective physiological workarounds that are hiding right in front of us.
It demands that we pause and ask why a treatment isn't working, rather than just doing the exact same thing harder and hoping for a different result.
Exactly. And that leaves us with one final provocative thought for you to mull over as we wrap up this deep dive.
If aggressively restricting sodium in these advanced diuretic-resistant heart failure patients actually triggers a physiological panic response that makes their condition actively worse, how many other traditional dietary restrictions in chronic illnesses might actually be inadvertently sabotaging our medical treatments?